Good morning. Thank you very much for the kind invitation and presentation. I'm Andrés Vásquez. I'm professor from Ghent University in Belgium, and also co-founder and CTO of Azalea Vision. So I will come a little bit from a different angle compared to the previous presentation. We're working on medical devices, so we're a medical device company. We were founded 3 years ago as a spin-off from IMEC and from Ghent University in Belgium. And as I will try to explain today, we developed smart contact lenses in order to improve the visual acuity, the visual quality of several group of patients. And then we do this through all the typical startup phases, raising money, and ultimately going to clinical trials. So in this presentation, just one sec. Okay. So in this presentation, I would like to explain a little bit what we do at Azalea Vision and why we do it, and then explain the angle I was mentioning, how we actually manage the amount of light that enters the eye, and in this way we can improve visual quality of group of patients. And then I will show you some of the results we have gotten for patients with aniridia and keratoconus, so with irregular astigmatism. At the moment, all these are in silico trials, so this means that we have done using optical models of the eye. We can do a lot of optical simulations, and we can show how a device like the ones we produce can help these patients. And then I will finish with some conclusions and perspectives for some questions. In the picture on the right, you can already see a little bit the technology or the approach we want to take. So what we would like to do is to place all this technology electronics I will show you in a moment inside of a contact lens, something that you can put on and off, and then use it during the day, and then during the night just remove it as a normal contact lens. So at Azalea Vision, as I mentioned, we're a medical device company. We're about 11 people now based in Belgium, in Ghent. And the main goal is to improve visual quality of patients, and we do this by using a lot of functionality inside of a contact lens. So you will see in a moment we will put silicon chips, batteries, antennas, etc. So we come for a very strong technological background from Ghent University and IMEC, and we have spent between 10 and 15 years working on this project to get it to this point. I will show you where we are today. And as I mentioned, one of the main focus is to basically to manage the amount of light that enters the eye. And of course, luckily, many of us, we have the iris and the pupil. I don't have to explain to this audience very well this, but here I want to highlight two of the main functions of the iris and the pupil, of course. One is to control the amount of light that enters the eye, and this happens autonomically. But on the second hand, we can also control the depth of field. So this is an optical effect that happens automatically at the same time the pupil opens and closes. And this is also very important for us to see well. This is the same effect we see in photography when you change the aperture size. So in these pictures you can see when the pupil or when the aperture is very big, then you can only see a small part of the picture in focus. But the moment you can, like this one here, but the moment you can close the aperture or the pupil becomes smaller, then more planes become clear, and then you can see an image sharper. This is one of the reasons also why we can see better when there is a lot of light, because on one side the depth of field is higher, but also because of course the noise on the retina becomes lower. So at Azalea Vision, we, of course, as a startup, a small team, we need to focus and we need to say exactly what we're going to do, and we have many ideas, but for the moment we are focusing on bringing back some visual quality for this type of patients. So first, regular astigmatism, so these can be patients with keratoconus or with irregular cornea, where of course they have a lot of high order aberrations in the system, optical system. I will show this in a moment. And also in aniridia, where the visual quality is lower, and of course we have a lot of light sensitivity problems. So in combination for these type of patients, the visual quality is relatively poor. And then what are these optical aberrations? So they are typically categorized in lower order and higher order. So the first row that we see here, this is some simulations to represent what type of aberrations they consider. And then these are what we experience as myopia, hyperopia, astigmatism, or defocus, just presbyopia, for example. And these are the typical type of aberrations that we can easily correct with glasses or with contact lenses. But then on the bottom part of this plot, you have these three rows, and of course this can continue even lower, is what we call the higher order aberrations. And this is what we experience as, for example, glare or halos or starburst. And they have many different names, and optically they have different sources. And basically they arrive or they happen because of the shape of the cornea, because of the shape of the crystalline lines. So all the optical system combined generate this type of optical aberrations. So at Azalea Vision, we have asked this question since many, many years. What if we can provide a solution that can adapt automatically to the amount of light, or by command, that we can tune and we can set the aperture size, that doesn't require any surgery, and in this sense that you can put on and off the contact lens in order to improve your quality of vision, and then finally that we can have something discrete and aesthetic. So this was the main requirements that we have as a team, and this is what we're trying to solve during the last couple of years. And then this is a schematic of the solution that we have in mind. So we develop a smart platform that we see here, and this is going to be placed inside of a contact lens. So the platform contains around the periphery of the device an antenna to communicate. We have some micro battery, we have a microchip in the center part, then we have a liquid crystal cell which is going to help us change the size of the pupil. So this is an animation of one of the user cases. So again, here we have the main components, and the main functionality is that depending on the amount of light or by command, we can change the aperture size which is placed in front of the cornea. And I will explain why this is very important for us to reduce these higher order aberrations. Then we plan also to put an artificial iris around to hide the electronics. And then, as a typical electronic device today, at night you will remove it from the eye, you will put it in a special charger where you can clean it with a typical liquid that you use today for contact lenses, and then you can recharge the battery, and then it's ready to run again for the next iteration. So typically this is a device that today is being done on rigid contact lenses, so these are RGP, a little bit bigger, so scleral. They will land on the white part of the eye. And in that way, we do not touch the cornea, so we always overhaul the cornea. In between, we have this saline liquid. And then we can clean it with the typical solutions, even with peroxide type of liquid to clean contact lenses, so it's also compatible with that. And then why this type of pinhole effect is important? So on a healthy eye, regarding higher order aberrations, of course, a complete optical system allows for the light that comes here from the left to land into the retina, and then we have a sharp image into the fovea, into the retina. But then, of course, if you have any type of deformation, just geometrically, that the cornea is not spherical, that it has some astigmatism, etc., then we can introduce lower or higher order aberrations, and then you can see here, maybe not so clear, but then the image is not anymore sharp in the retina, and then you don't have a sharp vision. Then today there are solutions, for example, glasses or contact lenses, and they can correct for the lower order aberrations, as I mentioned before. So here we can push back again all of the image into the retina, but still, as you can see here, compared to the first one, this is a very small, sharp, reaching the fovea, but in this picture, then you have a much wider circular confusion, and for this reason the image is still blurred and it's not very sharp. And then finally, what we do by introducing a small pinhole is that we have the same solution as a normal contact lens, but on top of that, we can actually filter out light which is aberrated, and we do that before it reaches the cornea. So we can actually decide, you saw this pinhole appearing in a contact lens, we can decide the size of this pinhole, but also we can decide the position of the pinhole. So based on scanning of the eye, which I will show in a moment, we can actually determine what is the optimum position for the pinhole in order to filter out all the aberrated light and to allow only the good light, if I might say. And then, as you can see here now, the light that passes through the artificial pinhole is then going to reach the retina, and then you have a sharp image. So up until now, all these schematic and presentation look a little bit like, some people might say, science fiction. But actually we are doing this, so this is actually happening. And this is me. I was the first one to try the contact lens, risking my, my eye, but everything went fine. So this happened in December last year. We developed the complete technology. We have many partners after 3 years of hard work. Then we arrived to the first embedded solution that we see here on the right. So this is a complete solution, autonomous, and is the first autonomous smart contact lens in the world, I can say. That means that we have a battery, it really functions on its own. And then I put it on my eye just to demonstrate that it's not yet a product, of course. We need to now engage into clinical trials, but it really has the form factor of a contact lens. It was fitted for my eye based on the shape of my eye. And inside we have these three main components that you see in the bottom. So on the left, of course, you have the liquid crystal that can turn on and off. We can change the size of the effective size of the pupil, as you can see in this animation here on the left. The center is a picture of the microchip. So this is a very, very little chip, just 1 by 1 millimeter. So everything is very small. And this is what controls the complete system. And on the right is just the connections, the circuitry, everything made in gold, which is biocompatible, in order to connect all the different components. Then on this next section, I would like to show more results on this in silico clinical trials in order to show the type of results that we can expect from the clinical trials later on. So we did some simulations with patients with aniridia. We got data from a hospital in Madrid. And then this is, for example, an OCT from one of the patients in which the diameter of the pupil was completely much bigger than normal. And then this on the right is the representation of the image, the letter E, that should be projected at the retina of this patient. This is only purely talking about the optical system of this patient. Then if we start to place our device, in this case 6 millimeter diameter, and then in the simulation we can actually start to close the rings, and then we can see how on the right side the result of the simulation, how we can bring back optically some of this visual quality for the patient. Also you can notice at the same time the contrast, so the difference between the black color of the letter E and the white background gets lower and lower because less light enters the eye. So this also happens at the same time. But as we know with our own eyes, the moment that you enter into a dark room, the sensitivity of the retina increases, and after a few minutes it will be very difficult to notice this difference in contrast in this between the black and the white. So here we started to show that actually this type of very small pinhole placed in front of the cornea can bring back optically some visual quality for these patients. And then next to this, we wanted to show that it's also possible to reduce the higher order aberrations, in this case especially for patients with keratoconus. So based on the eye model developed at Ghent University by Professor Jos Rosema, this is a completely optical eye model. It's based on 18 different independent parameters of real patients, more than 150 keratoconus patients. Then he was able to produce what he calls a synth eye model. So this is a synthetic eye for a computer simulation that you can have then random eyes, any number of eyes, with realistic values of the shape of the cornea. which can represent then patients with keratoconus. So then we use this type of models then to not to do one eye or two eyes, but we can do now hundreds of eyes to show statistically how our device can help the patients that we want to help. So what is the methodology that we have? So the first step is to take a scan of the eye. So now there are quite new tools to do this. For example, you have the Oculus Pentacam, where you can take wavefront a barometer of the complete system. And also you can have a topography of the eye. And the two things are important because from the wavefront you can know all the optical parameters of your system. And from the topography you can know the shape of the eye. And for us the shape is also important, especially the shape of the sclera, so not only on the cornea, because we can use that data to fit the contact lens. So that's the second step. So here you can see, for example, on these black dots, this is what it comes from the topography tool. So this is more than 5 million points of the shape of my eye. And based on that, the blue color that you see in a computer, we can then fit the shape of the contact lens that fits nicely to the shape of the cornea. And of course, after that, we can then design a custom-made contact lens for this patient. But of course, before we design the contact lens, we also need to decide where to put the pinhole. So of course, in our eyes, normally the pinhole is in the center, and okay, can be aligned to the visual axis or not, but it's more or less in the center. We can do that. But for example, here we see a topography image of a patient with keratoconus, where typically the bottom part of the cornea is a little bit bulging because it gets thinner. This is one of the reasons. So most probably in the center is not the best solution. So then what we do, using this eye model and these optical simulations, we can put the pinhole in different locations into a grid, for example, of 2 by 2 millimeters. And then we start to simulate what is the best visual acuity that we can obtain if we place the pinhole in this location. Until, for example, in this case, which is also linked to the shape of the cornea, it's better to put the pinhole in this area. Then the light will pass through that area, and all the rest it will be blocked. And in this case, we can then improve visual acuity. So we did this experiment now with 100 of these eyes, and now we're doing this. It just takes time, computer time, to do thousands of them to show statistically how this can help the patients. And in this plot here, every dot is one of the eyes of keratoconus, and the colors from 1 to 4 represent the stage of keratoconus, depending if it's very severe or mild deformation of the cornea. So typically we see here that most of the patients, if we put the pinhole in this round circle, which is about 1 millimeter in diameter, we can help them quite a lot. But there are many patients that we need to actually put the pinhole, as I mentioned before, not in the center part, but a little bit towards the bottom part of the cornea. And then what did we find with these simulations? So this is represented in this plot. So here in the bottom part, we're focusing on what is the natural pupil diameter. So again, for this group of patients, the pupil and the iris is working fine. And depending on the amount of light, it can go from 2 to 4.5 millimeter. And then on the y-axis, we have what is the visual acuity gain compared to the standard of care today, which is scleral contact lenses without any electronics. And then again here, every circle is one eye. We did the experiment for 100 eyes. And then here, very interesting, we see that for stages 2, 3, and 4, which is the colors blue to the gray, we see that basically we can improve visual acuity of at least one line for 100% of these patients. So here we start to show some statistics of how many patients from a group of 100 we can help using these techniques. So clearly we cannot help everybody in the same way, but for example, again, stages 2, 3, and 4, basically all of them we can improve at least one line. And for example, at stage 4, we can improve at least 2 lines of visual acuity for more than 90% of the eyes. So this again is a nice validation of the concept that we are achieving. We are also trying to now publish these findings in a peer review article as well. And to show you a little bit of the results, how they look like, this is the simulation of one of these 100 patients. So here on the left, you see the image projected into the retina. So again, we have the typical Snell chart, letters E, and then you see how for this particular patient it's quite blurry without any correction. This is looked at a distance of 1 meter, and then we have here the size of the letter on the blue color. So for example, this is a letter size of 7.2 millimeters located at 1 meter of distance. Then on the second column, we see the same patient, but now using the best standard of care solution today, which is a scleral contact lens without the electronics. And then clearly this provides an improvement. So we improve in this case a couple of lines, but then it's still at 3 millimeters, 1 meter distance, it starts to be blurry. So for this patient, it will be difficult to read a book or to read a computer screen. It will be still too blurry. And then on the final column, then we can show how the moment we start to close this pinhole and the moment we place it in the optimized location as I showed before, then we can go down to 20/20 vision. In this case, at 1 meter distance, you can read a letter size of 1.5 millimeters. So again, all these in silico trials are showing that the concept is working, and we're working hard at the same time on the technology, how to bring all these electronics and things inside. And then for the next steps, once now we finalize all these technological developments, we will start the clinical trials next year in sites in the US and also in Europe. Thank you very much.
Thank you very much, Andrés. And this is very interesting because yesterday we heard from Vito, who gave the talk about artificial iris implants in aniridia and how those could be potentially very detrimental with increasing the intraocular pressure and so forth. So this could be very interesting. Can you say anything about specifically aniridia, and has it been, are you planning like the trials with aniridia patients, or what are the plans there for aniridia population?
Yeah, so there we are still looking for the best strategy, especially from the point of view of PIs and centers in Europe and US. We have discussed now with centers in the US based on focus on keratoconus. They call it an epidemic of disease. And in aniridia, we are in constant contact as well in Belgium in order to try to start clinical trials in Europe. So we don't have a precise date or timeline for that, but it's our focus to, indeed work for a clinical trial in Europe.
Okay. And then for a follow-up question. So what is the expected lifetime of this device? So if someone should buy it, does it have to be replaced after like 5 years, or how can it last for a long time?
Yeah, so the typical time is 1 year to 15 months.
Okay.
Especially because the material of the contact lens starts to be scratched and it's more difficult to be contaminated. Yeah. So if you don't have electronics, also it's recommended to change it every 12-15 months. So it will be the same.
It will be the same. And cost, what do you estimate? What would be the cost for one of these devices?
Sure. Yeah, I think there will be there are still today differences between US and Europe, and also the reimbursement systems, US, Europe, every European country is also different. We don't have yet a price, I can say today, but it will be in the order of hundreds of euros per device.
Yeah, okay. But I mean, if it can improve vision, a few hundred euros.
Hundreds of euros.
Yeah.
Yeah, so I don't have a precise price, but it will be like between 500 and 1,000 euros per device, per pair, yeah.
Thank you very much for the presentation. I have a question. For the aniridia patients, we have understood that it's good to not use contact lenses because of the sensitive area of the limbal stem cells. And I wonder, have you thought about that? Is it like the material that allows it to be used for aniridia patients, or?
Yes, that's a very good question. So since the beginning, when we talked to ophthalmologists treating aniridia, we had the same reaction, especially when we said contact lens. Just like that, they always imagine this soft contact lens that, of course, touch the cornea and the limbus area. And for sure, those ones, they do not recommend it. The moment we started to explore together with them that this is a scleral contact lens, which does not touch the cornea and does not touch the limbus area, but only the sclera, then there are some clinical trials going on with patients with aniridia with scleral contact lenses because of this reason. Also, it's been used for dry eye syndrome, for example, which is a little bit counterintuitive to put a contact lens if you have dry eye. But the advantage is that you always have a layer of liquid in between the lens and the eye, which helps for the dry eye.
And do you think for the same reason that maybe the patient is not as dependent on the artificial teardrops? Do you think that an aniridic patient, if one uses the lens that you showed, maybe does not need to drop these artificial drops as often as is usually needed, or?
That could be one of the benefits, because we see this in patients with dry eyes as well.
But in case it is needed, do you think that one can drop these artificial tears at the same time as the lens is in place?
So typically,
is it compatible?
There is always a flow of liquid from the outside to the inside. So it's not that the liquid stays there for the whole day. There is some, underneath the lens, there are some pads for the liquid, the tear fluid, to flush, let's call it, the liquid that is inside. So the moment you can put drops, they can also permeate and go underneath the lens and then into the cornea.
So the patient doesn't need to take out the lens, give the drops, because not all the lenses are compatible with artificial tears. That's why I ask.
Yes, correct.
So this one can be used with artificial tears?
Yes.
Thanks.
Just a comment and then a question. Excellent presentation. So we do use scleral contact lenses for aniridia patients because of the reasons that you mentioned. It's safe, and some patients have highly significant irregular astigmatism and they need it, to be able to function better. But the comment is that aperture optics is now one of the hottest areas of ophthalmology, in particularly looking forward into new intraocular lens designs and treatment of keratoconus. You can modify the patient's pupil if they have an iris as one approach, or you can put it in the lens if you're putting it in an intraocular lens. But it's a very, very hot area right now, and there's a lot of interest in this. So speaking to that, I mean, obviously, we want this and need this for aniridia patients and keratoconus patients is great. Have you been, as your slide says, they're looking forward to the intraocular lens area because this would have obvious applications there, and there's a lot of interest in that right now, and it's a huge market.
So your question, you mean if we?
It's hard to to put the electronics in an intraocular lens, but have you been thinking about intraocular lenses?
Yeah. The short answer is yes. So we're familiar also with all the developments in smart pupil research, because it's a little bit basically what we do as well. All the stories of AcuFocus, for example, which is a pinhole IOL, and all the stories of the VUT drops for presbyopia, where you put drops and the pupil changes in size. And all those things, they have this advantage compared to our solution in terms that you cannot control the size, you cannot control the time, and also the long-term effects of these drops in the muscles is also unknown a little bit. So yes, we have been thinking about putting this technology in an IOL, similar to the AcuFocus lens. Of course, technologically it's more challenging. That's clear. Now we started with the first step, which is to put it on a rigid scleral contact lens. Then immediately we can think of soft contact lenses for other applications. And then thirdly, we can think on IOLs, smart IOLs. So we just finished a postdoc European project on smart IOLs. And the intention is to put, again, electronics into an IOL. Then it will be a little bit less complex than we have here. So, because if you think to put a micro battery inside an IOL, it starts to be very complex also to prove safety. But we believe that with this type of devices, we will create a pathway, especially towards the regulatory agencies like FDA, etc., that these devices can be safe in order to take the next step to go into smart IOLs. Yeah. Thank you.
May I?
Yeah.
Just one comment and one question, perhaps not for you. The comment is that also corneal contact lenses and scleral contact lenses are quite old as idea, as a proposal.
Mm-hmm.
But our problem as a parents is that it's not so common for an ophthalmologist to suggest to use corneal and even scleral contact lenses because of, sorry, I'm going to be rough, because they are not so expert in contact lenses or scleral contact lenses. So parents have to search on their own some way to find this kind of solution, and you meet some optometrist, but they know almost nothing about physiology, aniridia, and what else. And so what could happen that we are in the middle of something of lack of knowledge, so we are not able to understand what is the real use of the scleral lenses. The optometrists are not able to understand if they can be used or not, and the ophthalmologists are not well aware about the use of this lens. So the real point and the crucial point is just to make ophthalmologists more aware about this kind of devices in order to make them able to suggest to patients the use of these devices. Otherwise, it will be impossible. Another problem could be also that the scleral lenses need to be done on a customized way. So I have to go, let's say, I have to come to Ghent, you will measure and map my sclera, and then I will have my contact lens. I will be back in Rome. The day after, I will have a problem. I have to call you, Andrés, there is a problem. I'm going to go back perhaps to Ghent. That is not the best in terms of... But, and so this is just one comment, but a question perhaps for the ophthalmologist, for Professor Nagali or Ferrari or what else, would you suggest the use of these contact lenses in case of cornea or eyes with some problems, such as scars or perhaps with dry eyes cases? Because one of the problems could be this one. Perhaps the people with problem could have more advantages from these lenses, but can they use the scleral contact lenses that are fantastic from my point of view, even though they have problem?
Yeah, I would like to help with the technical. Yeah, we all have to remember that the main problem for aniridia is macular hypoplasia. Whatever, like this very, yeah, my respect, because I like ophthalmology technical guys. We also have like guys putting something like IT device in the brain, and then for blind monkeys, and then they start to see. So it's like good. It's really, I respect it very much. But we have to understand, like this device, if I'm saying right, just correct me, for a normal eye with good macula, with good optic nerve, but then have some ophthalmological and other problems, but not for us like the cure for the disease. Like never aniridia kid would have like 10% of vision. With these lenses, we'll see 100%. It will never happen. So once we understand this as a fact, then we look at this as like, okay, it's a very good device, very like advanced in these days and can be useful for a lot of people, but not, sorry, for us. I mean, in a very basic understanding of the disease. That's it. So it's like responsibility on us, on users. Of course, like you said, yeah, ophthalmologists, they will recommend. But probably in this case, when we're speaking about finance and about like some project with money, they would like to sell it, you know? But then it's like, it's our responsibility. Will we buy it? To do what? To protect, like, since photophobia?
Well, I can put a different perspective on that, too.
I mean,
however, Agree with that. However, the challenge is a lot of times we'll have a patient that has 20/60 vision, 2100 vision, and they drop to count fingers or something like that. So there's a progressive decrease of vision over time, and many times that's due to the irregular astigmatism, corneal opacities, other issues with keratopathy, and other things. So what somebody wants to do is to maintain their functioning, and a lot of times in ophthalmology we're faced with a challenge of how do we get that person, how do we keep that person functioning like they were? Maybe it's not 20/20, but maybe it's 20/60 or 2100. That's the challenge. And many times we do use scleral contact lenses. Now, it's pretty routine for us to try to do that, to get them back to some functioning if they have a decrease that we can identify as in the cornea. But that's the place for this lens in aniridia, is you've got a situation where we have that change in the vision that occurs during life that is really frustrating and problematic for the patients and the doctors, and we're trying to sometimes maintain what we have. So I think in that sense, I agree with your comment. It may not be 20/20, but hey, we're happy with 20/60 many times or 2100, and that's a much better thing than count fingers due to irregular astigmatism and other problems with the cornea. So I think, my view as an ophthalmologist is it does have a role. It can be routinized in clinic. We have a routine thing that we have set up that we just send them over. They get their contact lens made, and we really don't have to think about it very much. But basically, I do think it does have a very significant role in clinical care in the sense that our biggest challenge is that how do we keep people, at the same level of functioning? So just a small comment about that to follow up on that.
No, I think that's very, very pertinent comments, and also I think we have to keep in mind. Yes, of course, they have the foveal hypoplasia. Yes, but we should also keep in mind that right now there are surgeries being done to implant artificial irises, and if we think about that, I think this is a much better solution. Yeah, so I think we shouldn't lose sight of that as well. But we will take.
And I just want to finalize with one of the comments from the audience is about how old contact lenses are, and indeed this is a couple of 100 years old technology, and we're trying to bring a little bit a different perspective to, if I would say, to bring them back to be sexy again, so people really know what they are, and ophthalmologists get intrigued and they can prescribe and they understand how to do it. And I believe that as a startup and high-tech and med-tech type of device, we can bring this edge to these medical devices to really have extra functionality for the patients. Yeah. But thank you.
Thank you very much.